So good afternoon, everybody. Would first like to thank Dr. Junaid and Dr. Aiman for inviting me and my colleagues at the Children's Hospital of Philadelphia to speak at this wonderfully informative and cutting-edge conference. As Dr. Aiman mentioned, that this is my fourth year speaking at this conference, and I really am hoping that the next time we and my colleagues from CHOP are speaking here, that we'll be able to see our good friends in the UAE once again in person. Now, I did offer two potential talks for this conference, but I'm only going to talk about one of them, which is issues around caffeine therapy and monitoring for apnea, particularly through the end of the hospitalizations. And we're going to have some special emphasis on discharge issues. So my disclosures are shown on this slide. As Dr. Aiman mentioned, I'm currently on 2 research grants funded through the NIH, which are relevant to my topic today. And I do have one disclosure in that I will be discussing unapproved use of caffeine in premature infants during my talk this afternoon. So methylxanthines such as aminophylline and caffeine have been used in NICUs to treat apnea of prematurity for decades. Dr. Barbara Schmidt's landmark Caffeine and Apnea of Prematurity, or CAP trial, as she outlined brilliantly on Thursday morning at this conference, was conducted as a pragmatic international placebo-controlled trial of caffeine administered in the first 10 days after birth in preterm babies less than 1,250 grams birth weight. The primary outcome, as Dr. Barbara outlined, was neurodevelopmental impairment at 18 to 22 months to primarily address the safety of caffeine in this population. This trial definitively established that caffeine at the doses used was safe in preterm infants. As you know, and has been reviewed also at this conference, the other important and somewhat unexpected findings in this trial was a significant reduction in the incidence of bronchopulmonary dysplasia, or BPD, and improved neurodevelopment in the caffeine-treated infants. The reasons for these benefits remain unclear, but could be a direct pharmacologic effect of caffeine on the lungs and brain, or secondary effect through caffeine's primary pharmacologic effect in reducing apnea and subsequent hypoxic episodes, which could be injurious to the developing brain. Now, caffeine is now one of the most widely prescribed drugs in the extremely low birth weight population, really only second to antibiotics. And unlike almost all other drug exposures, its duration of use is measured in weeks. But in usual practice, stopping caffeine and monitoring for resurgent apnea events for several days is a typical discharge criteria in most NICUs. After publication of the CAP trial, there have been several drifts in practice in the use of caffeine in the NICU that are not consistent with what was studied in that trial. Much of these were reviewed by Dr. Eduardo Boncalari in his talk on Friday. As Dr. Boncalari gave us the information on, multiple observational studies concluded that early caffeine use, usually described as starting at less than 3 days of age, was associated with the reduction in BPD, as well as improved neurodevelopment, whereas later start times were not. This observation led many NICUs to prescribe caffeine in nearly all ELBW babies on the day of birth, both as a prophylactic treatment in the hope to prevent BPD, but also in some centers as a quote-unquote neuroprotective drug. In addition, several published international guidelines also suggest that doses of caffeine much higher than those studied in the CAP trial be used for more severe apnea. So we know that doses as high as 40 milligrams per kilogram loading and 20 milligrams per kilogram maintenance dosing are used routinely in some United States NICUs. Now, I believe there are several potential safety concerns of these practices, in that the mean gestational age of infants included in the CAP trial was 27 weeks, and infants at borderline viability who are most likely to require prolonged mechanical ventilation and perhaps might be at most risk for adverse drug effects were underrepresented in the trial. So it is not clear whether the same benefits and safety profile extend to the youngest gestational ages. In addition, while there is some efficacy data of higher doses of caffeine than were used in the CAP trial, there is complete lack of safety data at these higher doses, which can potentially be pro-inflammatory. And finally, and even more poorly studied, I will talk about a bit later, some sites have elected to use caffeine at discharge for home therapy as well. Despite widespread use of caffeine, there has been much attention in recent years to the phenomenon of intermittent hypoxemia, or IH, which is the focus of my research currently. It is defined as periodic episodes of hypoxemia with a return to baseline oxygen saturations, which may be prolonged or very brief in duration. The diagnosis of IH is dependent on the use of continuous pulse oximetry, which is almost ubiquitous in most NICUs. However, NICUs use a variety of averaging times in their oximeters, which can affect the detection of IH, where long averaging times will only detect prolonged hypoxemia events, but reduce the incidence of alarms, whereas shorter averaging times can detect very brief episodes of IH, which are currently of uncertain clinical significance. We do know from a number of studies that IH is very common in extremely preterm infants, but it is more frequent at older postnatal ages, with a peak incidence at 4 to 6 weeks, when periodic breathing is most common. It is also more commonly seen in infants with evolving bronchopulmonary dysplasia and those maintained at lower oxygen saturation targets, which currently are likely not being used in most units. So this graph shows the distribution of IH by postnatal age in infants born at less than 28 weeks gestation. And you can see that there are many, many hypoxemic events per week in the hundreds, which peak at about 4 to 6 weeks of age and only slowly decline thereafter. As I will show you a bit later, these events also persist in many, if not most, convalescent preterm infants at the time of discharge home. So we know that these IH events are common, but is there any evidence that they are harmful? There have been several observational studies which have tried to address this issue. Here, I am showing one study from Dr. Richard Martin's group in Cleveland, Ohio, which showed an association of a greater frequency of IH with severity of retinopathy or prematurity, with babies who required laser therapy for their ROP, showing a higher number of IH episodes per week. Another study from Dr. Christian Poets analyzed data from the Canadian oxygen saturation targeting trial, in which babies less than 28 weeks gestation at birth had continuous pulse oximetry recorded until 36 weeks postmenstrual age. Dr. Christian found that when subjects were divided into deciles of time spent with oxygen saturations less than 80%, those with the highest amount of time with lower saturations compared to those with the least had a significantly higher risk of death or severe disability. Of course, these studies show an association, not direct causation of IH with poor outcomes. But as this model shows, suggested by Dr. Richard Martin's group, one possible hypothesis is that frequent, severe, or prolonged episodes of intermittent hypoxemia through several different mechanisms, including an increase in the inflammatory response, neurotransmitter imbalance caused by episodes of hypoxemia and reoxygenation, and production of reactive oxygen species induced by these repetitive hypoxemic and reoxygenation events may directly result in the development of poor outcomes through brain injury. These more severe and prolonged events, which tend to occur in the NICU earlier in the hospital stay, may need to be treated aggressively to prevent injury.
Well, that
However, there may be milder and therefore lower risk IH events, which may or may not have implications for outcomes and may not need to be treated.
This is the one with my heart.
So studies have informed us if and when to use caffeine in the premature baby, but when should we stop it? This aspect of caffeine use has been poorly studied and really is truly based on practice and expert opinion. In the CAP trial, which was pragmatic in design and left the decision when to stop the study drug up to the clinical team, the median age when the drug was stopped was just over 34 weeks postmenstrual age. A recent clinical report from the AAP Committee on Fetus and Newborn recommended stopping caffeine if the baby was event-free for 5 to 7 days off positive pressure ventilation, or at 33 to 34 weeks postmenstrual age. Now, I was the primary author of this guideline, and I can tell you that this recommendation was really based on no data, but was designed to prevent delays in discharge and to be sure that caffeine had been cleared while awaiting an apnea-free period prior to discharge. The goal of the committee's statement was to recommend that caffeine be stopped so that there was no delay in discharge home. So this graph shows the pharmacological and clinical data around what happens when caffeine is stopped. In the upper right panel, you can see how long it takes to clear caffeine from the serum with persistence of a therapeutic level for many, many days. Really, this doesn't start to decrease until about 5 to 6 days after discontinuation. This long half-life is one of its advantages as a therapeutic drug and why we were able to administer it once per day. But it is important to recognize in the development of a policy for an apnea countdown and transition to home. And in the lower left panel, you can see that as caffeine levels fall, there are breakthrough apneic events, reinforcing the need to monitor for a period of time if you stop caffeine prior to discharge home. Now, as in most practices, when there is not an abundance of evidence, but an overabundance of expert opinion, there is a lot of variation across NICUs as to what postmenstrual age when caffeine is discontinued. This one study of over 81,000 infants, less than 1,500 grams birth weight, who were treated with caffeine in several hundred NICUs across the United States, showed that there was significant variation, as you might expect, with the median postmenstrual age at stopping caffeine ranging from 32 to 37 weeks postmenstrual age. However, as I alluded to earlier, we also know that intermittent hypoxemia persists even in the convalescent preterm infant and probably worsens after stopping caffeine. This tracing shows recorded high-resolution oximetry with a very short averaging time in a preterm infant after stopping caffeine. You can see on the left at 36 weeks postmenstrual age, while the baby is still hospitalized, the baby has multiple clustered episodes of oxygen desaturation, which improve but persist as late as 38 weeks postmenstrual age in a recording made at home after the baby was discharged from the hospital, seen in the right panel. This pattern of brief but clustered episodes of IH are very common, particularly in very preterm infants who have had a history of apnea or prematurity or have bronchopulmonary dysplasia. IH is also common in late preterm infants. As seen in this figure from a very recent study in babies delivered at 34 to 36 weeks gestational age, on the panels on the left, you can see that these late preterm infants had relatively frequent events of desaturations of at least 10%, which increase over the first 2 weeks after birth, probably because of an increase in periodic breathing, and then decrease thereafter. Now, this study also included a term control group, and interestingly, term babies also had intermittent hypoxemia in the first 2 weeks after birth, but these events were not as frequent or severe as in the late preterm infants. Now, these data perhaps are not surprising, since respiratory control is not an on-off switch, and unstable control mechanisms may still be in place even after 34 to 35 weeks in many babies. So what can, and more importantly, should be done about this persistent IH in preterm infants? Evidence suggests that persistent IH can indeed be treated. In this study by Dr. Larry Ryan and Carl Hunt, they randomized babies who were born at less than 32 weeks gestational age, who had been treated with caffeine for apnea, to extended caffeine citrate at 6 milligrams per kilogram per day, or usual care, meaning no caffeine, once the decision to stop clinical treatment with caffeine was made. They recorded pulse oximetry both in the hospital and at home. As shown in the graph, there was a reduction in episodes of IH at both 35 and 36 weeks postmenstrual age. But after 36 weeks, this beneficial effect of caffeine in limiting IH was no longer seen. Since it's known that caffeine metabolism increases after 36 weeks, these same investigators conducted a follow-up trial using higher doses at 14 and 20 milligrams per kilogram per day of caffeine citrate. With these higher doses, you can see in the graph that they were able to show a continued decrease in the incidence of IH up to 38 weeks postmenstrual age, seen in the red squares. So what should we make of these data? It has been suggested by several investigators that we as neonatologists should be concerned about the potential harmful effects of persistent IH in preterm infants, and perhaps extend caffeine therapy after discharge. It does work to prevent these episodes of IH, but it is not yet clear whether these are harmful. It is possible that simply not stopping caffeine could shorten length of hospital stay by eliminating the need for an apnea countdown as caffeine levels fall. I think there are at least two other unanswered questions about this practice. First, does it actually decrease length of stay as hypothesized? And if discharged home on caffeine, do babies need to also be sent home on a monitor in case doses of caffeine are missed or there is breakthrough apnea? In addition, since we have some data that extended caffeine can reduce the incidence and severity of intermittent hypoxia, is that a sole reason to extend caffeine to the home environment? It's not at all clear, as I mentioned, whether the IH we've seen in convalescent preterm infants is clinically important, and there is no evidence currently that a reduction in IH will improve neurodevelopmental or other outcomes. And finally, I think we run the risk of medicalizing what is a normal maturational phenomenon, which may not have any clinical significance to the individual baby. So somewhat sadly, that leaves us with the typical Cochrane Review conclusion that quote unquote more research is needed. Fortunately, there are at least 2 ongoing trials that I am aware of that are attempting to answer some of these questions. The first is known as the MOCA trial, or the Moderately Preterm with Caffeine at Home for Apnea trial, which is sponsored by the United States Neonatal Research Network with Wally Carlo as PI, and I am serving as a co-investigator. This study is a randomized placebo-controlled trial of extended caffeine in moderately preterm infants that specifically addresses whether use of caffeine up to and after discharge reduces hospital length of stay. So babies will be born between 29 and 33 weeks gestational age, are randomized to receive caffeine or placebo, and then will receive it for 28 days post-discharge, again with the primary outcome being length of stay. The second study, which Dr. Carl Hunt and myself are co-PIs, is a randomized placebo-controlled trial of extended caffeine in babies less than 32 weeks gestational age. This study has a primary outcome of reduction of the extent of IH exposure in caffeine versus placebo groups and includes recorded study high-resolution pulse oximetry in the hospital and at home. But it also has secondary outcomes of measurement of inflammatory cytokines, as well as a baseline and end of study MRI of the brain to explore whether decreasing the incidence of intermittent hypoxemia results in a less inflammatory bioprofile or less changes in the MRI of the brain. So while we await the results of these studies, I'll conclude with a few concrete recommendations for how to move the field forward, opinions that I think are indeed evidence-based. First, I think it is essential that all NICUs develop the common consensus on a rigorous definition of what is considered to be a clinically significant cardiorespiratory event to improve provider consistency. This can be done as a quality improvement project, which I'll show on the next couple of slides. Second, I think it's important to develop strict documentation guidelines for staff to improve provider communication for better clinical decision-making. Lastly, there should be a consensus from clinicians for what the duration of the apnea countdown should be and what events should count as clinically significant and delay in discharge decisions. My opinion is that until there is more evidence gained from the trials that I've outlined, routine use of home caffeine therapy should be used only sparsely, perhaps in infants who are otherwise ready for discharge, who have failed 2 or more apnea countdowns, and those apnea events do not require significant intervention. So as I've mentioned about a quality improvement project, what I've shown on this slide is a QI project that was done by my colleagues at the Hospital of University of Pennsylvania. They defined a clinically significant event as shown with a heart rate and saturation definitions and asked staff to only document events which match these definitions and specified when babies should have their caffeine discontinued at around 34 weeks post-menstrual age, consistent with the Committee of Fetus and Newborn recommendation, and recommended that infants should be off caffeine for at least 10 days prior to discharge. And they also recommended that all babies should have not be discharged until at least 5 days of the last recorded clinically significant event. So this was written into policy, taught to the nursing staff, and built into the electronic record so there could be greater consistency in the management of apnea. Now, I've shown on this slide the progress of this QI project, which was recently published in Pediatrics, with the top panel showing a more consistent approach to the duration of the apnea countdown, narrowing to more closely to the recommended 5 days. And the bottom panel showing a decrease in the standard deviation amongst clinicians in the duration of that apnea countdown. There was also improved nursing documentation, as well as nursing satisfaction with the discharge process. And this is just one of several published examples of apnea and caffeine management and progress towards quality improvement projects at the end of the hospital stay. So I will close with this one last recent study from the Vermont-Oxford network. They found a steady increase in the length of hospital stay and discharge weight from 2005 to 2018. Now, the reasons for this increase remain speculative, but in the paper, they speculated this may be towards different apnea management styles. But it is clear that how we make discharge decisions for preterm infants has many clinical as well as family and cost implications. So I thank you for your attention, and I do hope, as difficult as these virtual talks are, that it held your interest. And I know that Dr. Aiman will be hosting a Q&A session for all the speakers immediately after this talk. So thank you very much. And